Organophosphate poisoning is a medical emergency commonly encountered in agricultural exposure, pesticide ingestion, and toxicology practice. In this video, we'll review the immediate management algorithm for organophosphate poisoning, including recognition of symptoms, initial stabilization, atropine therapy, and monitoring for toxicity. Organophosphorus compounds are potent neurotoxins. Exposure may occur through absorption through the skin, ingestion, inhalation, or injection. These compounds inhibit acetylcholinesterase, leading to excessive stimulation of both muscarinic and nicotinic receptors. Muscarinic symptoms can be remembered using the mnemonics SLUDGE and DUMBLES. SLUDGE stands for salivation, lacrimation, urination, diarrhea, gastrointestinal upset, and emesis. DUMBLES includes diaphoresis and diarrhea, urination, meiosis, bradycardia, bronchospasm and bronchorrhea, emesis, excess lacrimation, and salivation. Nicotinic manifestations include muscle fasciculations, muscle cramping, diaphragmatic weakness or failure, and autonomic effects such as hypertension, tachycardia, mydriasis, and pallor. The first step in initial management is stabilization. Perform an ABC survey. Assess airway, breathing, and circulation. Establish intravenous access and initiate monitoring. Remove contaminated clothing. Brush off any powder residue. And thoroughly wash exposed skin. Carefully evaluate the patient for serious signs and symptoms. If required, administer a normal saline bolus to maintain systolic blood pressure above 90 millimeters of mercury. Serious clinical features include prominent sludge symptoms, hypotension, seizures, respiratory distress, and wheezing. If serious signs or symptoms are present, administer atropine, 2.4 milligrams intravenously as a bolus. Reassess the patient every 5 minutes and look for signs of improvement. Clinical improvement is indicated by clear lung sounds, dry airways, and improved oxygenation. If the patient does not improve, double the atropine dose and reassess again after 5 minutes. Continue dose escalation until adequate atropinization is achieved. Once improvement is observed, start a continuous atropine infusion. Calculate the total atropine dose required for stabilization, then infuse approximately 10 to 20% of that dose per hour. The patient must be closely monitored for signs of atropine toxicity. Signs of atropine toxicity include agitation, confusion, urinary retention, hyperthermia, and tachycardia. If atropine toxicity develops, stop the infusion for 30 minutes. Then resume at approximately 70% of the previous infusion rate while continuing close monitoring. Early recognition and aggressive atropine therapy are critical in reducing mortality from organophosphate poisoning. For examinations and clinical practice, remember, treat the patient based on respiratory secretions and oxygenation, not simply the heart rate or pupil size. Thanks for watching, and I would like to see you again. Please do subscribe if not already done. Have a great one. This content is not intended for clinical guidance, used in medical clinics or patient management. It serves as supplementary information for medical students preparing for examinations and should be used in conjunction with their official course materials. In the event of any discrepancies between this content and the prescribed curriculum, the curriculum shall take precedence until further review and clarification are made by the concerned students. The contributors to this video have exercised due diligence, but the content may become outdated quickly.